Thanks, Mr. Chairman, sir, and esteemed colleagues. The talk of today is very much related to Dr. William Inthomans, who was honored with Nobel Prize in 2024, just after 100 years of age. Just as a passage of the 100 years, I am presenting more or less the same thing here before audience. Here you see, next please. I want to salute Dr. William Inthomans due to the following reasons. He first invented the machine of EKG. Number two, he gave the nomenclature of different waves like PQRST to the even including U to the EC tracings. Number three, he was very much famous for the Inthomans triangle, which is the basis of modern ECG nowadays. And lastly, to say that Thomas Lewis, who was competent for the Nobel Prize, said after winning the Nobel Prize by him that this method of ECG would be familiar in due course of time when he made the statement in 1910. And now all of us know that it is so famous to be recorded in almost every case, needy case of the patient of cardiology. And Inthomans, no surprise that why Inthomans was awarded with the Nobel Prize in 1924. Right. Next, इसके पहले. This slide is very much important. I want to place three important things before you. Fundamental of cardiac discipline in connection with the ECG. The current flow from positive ionic state towards the negative ionic state. Just see from 0 state to the last word. Waves display as per voltage gradient like the say in the phase 0. Rapid entry of the sodium channels. So rapid entry, more voltage. So the QRS is having the highest amplitude on ECG. Just see the T wave. T wave is the gift of the phase 3, where the slow ionic channels are playing. So slow bit of the voltage, so somewhat lower voltage. So T wave is the somewhat lower compared to the QRS wave. Here you see that in phase 3, if hyperkalemia is there, the more surplus ions in the vicinity. That's why the amplitude of the T wave will be enhanced due to more gradient presence therein. And lastly, no voltage gradient if the complete deprivation either or complete deprivation of the no flow of the current, there is no wave and isoelectric line will be inscribed there. Next please. A normal wave, basic normal, is starting from the SA node to the AV node. In between the period, the atria, both atria are depolarized. When it reaches to the AV node, it travels downwards through the conducting system up to the Purkinje fibers. And before that, there is a Q wave, septal wave, from the left bundle branch. This septal wave is moving towards the right side. So it is the first negative wave, first positive wave, small wave is the septal wave. And if it is away from this towards the left side, which is thicker one, left ventricle, it is the negative side, away from that. So Q wave is the septal wave. Again towards the left ventricle, the thicker one is the R wave, and here is the downward wave is the R wave. And likewise, the third wave is negative S wave represents the R wave, where the negative S wave, positive R is small. The second wave represents the RV activation. All of you know that what are the leads 1 to 12 leads. 12 leads 1 to 3 AVR, AVL, FF, AVF, V1 to V6. Only I want to say here that you should keep attention to the lead AVR which is having all the negative waves therein. Next one. Here the flow of ionic currents from negative to the positive charge, from positive and negative charge particles have been demonstrated here from negative to positive charge. They create a fold of field of sort of the create a fold of the electrical field, and that's why I have demonstrated this very nicely here. Even from the endocardium to the endocardium, the same mechanism there. And the vertical plane, the aura is like this, and over the horizontal plane, the aura is like this. Just a visual inspection. Last please. We catch this electrical field by two methods, by vertical plane and by the horizontal plane. Or was vertical plane, we apply the three bipolar leads, this 1, 2, 3. This is the 1, this is the 2, and this is the 3. Plus unipolar lead leads, AVR, AVL, and AVF. And 6 horizontal planes leads V1 to V6. V stands for voltage here, and where there in the unipolar lead, V stands for the vector. One point to remember that we can record only electrical current to be recorded if there are two terminals, one is positive, the other is negative. In the case of the limb leads, there are two terminals, 1, 2 lead, 3 leads. But in the remaining of the leads, say in the unipolar amplified leads or the chest leads, there is only one terminal. That's why we have to create a second terminal negative and zero potential. By combining all the 3 limbs, arms, limbs, it comes to the 0. Circuit is closed by the Kirchhoff's law. It comes to 0. So we point 0 is negative charge. Next one, please. I shall be demonstrating next one. You see here, Ethiopian triangle. Negative to plus 2, then minus 2 plus, then minus 2 plus on the F sides. And these bipolar leads, unipolar leads, and the current of flow from negative electrode to the positive electrode, because the right arm and the right arm and the right eye and left leg, accordingly to the charge of the leads, they form the negative pole. And center terminal is the neutral pole, 0 point. By combining all the 3, it is responsible for the AVR, AVL, AVF against this 0 against the lead of the right arm, and left leg. And we want to fix center terminal. Center terminal is the 0 point. Then against that center negative pole, we record over the V1, V2, and so on. Next. Next, please. These are beautiful diagrams. One can say that it was the invention of myself. This projective geometry of the hexagonal system. This is a famous triangle of the Einthovens, no doubt. Nothing. He just invented the manifest electrical current flow out of the 3 leads, which is now known as electrical current, electrical axis nowadays. This diagram. In 1994, we organized a seminar on ECG, normal ECG. All the gear doctors were present there, and I was authorized to say something about the normal ECG, how to present this ECG. I was in a dilemma, and I just by 3 days, sleepless nights, I came to draw this diagram. Heart is lying at the center. So from center to the right, AVR, from center to the left, AVL, from center to the left leg, there is this part. So how one limbs like this. So I want to bring the lead 1 through the center of the heart. So it is come to 0 degree. Again the lead 2 to come to the 60 degree, just passing through the lead center of the heart, and lead 3 accordingly plus 120 degree, just like that. So this conception would give rise to the real genesis of hexagonal system. Otherwise, there are so many students I have taught, even the MD students, even the DM students, but sometimes when I ask what is the mechanism, what is the way of the expression of this hexagonal system, most of them were on the negative answer. No book of the world on ECG has illustrated this sort of the thing there. Next. This rule also, when somebody told me that I can calculate the electrical axis within a few seconds, I was surprised. At that time I was a resident in Department of Medicine, very earlier age, 84 like that. Then I thought, how is it possible? Then I formulated a law here. And any experience, just like that. If I am standing here before you, I can see on both sides, on either of the 90 degree range. But on this side, horizontal range, flatness. Beyond is the negative, darkness, negative. The same thing is applicable here. Any exploring lead placed within a range of 90 degree in response to cardiac electrical axis records positive current at 90 degree phasic deflection or no deflection or beyond 90 degree. That was the basis of my thinking. Later on, I admit that this was included in the field of the electrocardiography when I searched after 10 years of passage of time. So this is the hexagonal triangle, heart is at the center, and you have to only plot at least in mind what about one axis AVL, keep against the minus 30 and so on, one axis 0 degree and 60 degree lead 2 and so on. The electrical axis is imaginary now, we have to withdraw it. How to withdraw it? If you see the 1 and 2 leads showing both the positive waves, is the normal axis which lies in between the 9 plus 930 to plus 90 degree. The right axis deviation, rightwards, means 1 is negative and the 2 positive. If the reverse is there, left axis deviation. If northwest axis deviation, both the leads are negative and positivity more towards the northwest side, is known as vested exhibition. Only this much of thing is required. It is not necessary to calculate the axis very accurately, minus 59 degree or so on. In practice of clinical practice, only this much of required. Normal axis, right axis division, left axis division, left axis division, not west division. Next. Next, please. There is somewhat different flow of the current over the horizontal plane. Don't calculate the axis here, because left ventricle is thicker than compared to right ventricle. The current starts from the SN node coming to a conducting pathway and just diverges towards both these things. Since left ventricle is more thicker compared to right ventricle, so more positive waves are recorded there. Of course, I have told that it is away from the left ventricle, so there are negative Q waves there, more thicker right wave, and the S wave, just a 3 diagram, there is no left extreme diagram. 3 is the negative wave, representation of the right wave. Just the mirror image is over the V1, nothing else. So if you can say, next. This is my computer main chest original diagram. My computer means I have prepared this combination by the frontal, even the original pleats. How could we explain all the things? Nothing else. Here, paper speed. The electrographic paper is not the stationary paper. It moves with the speed of the ECG machine. On stationary sides, one big square contains the horizontal 5 small squares and the horizontal vertical 5 small squares. One small square is equivalent to the 1 millimeter. So if the paper speed is the 0.05 millimeters, 1 minute width will be like this. And if the 25 millimeter per second, that means it will cover the 5 bigger squares. PR interval includes both even the AV nodes. So if PR includes the PR interval is more than that, it means the first AV block will be there like that, likewise. Installation, if you do the diffraction to the stylus by 1 millivolt, it will go upward by 10 millimeter. P wave includes the P atrial deposition. PQ includes including the atrial deposition plus the stationary part when the atria are completely depolarized. There is no question of the current formation. But even downwards, if it goes downwards up to the Purkinje fibers, there is very minimal amount of the current formation. That's why there is no current flow. That's why PR segment, PQ PR segment, I would say, is isoelectric in appearance. QRS already I explained to you. ST segment, very important segment. Why it is formed? It is formed due to the exchange of the calcium ions against the potassium ions. Both are in equilibrium. That's why stationary isoelectric line is there. Why isoelectric line? Because below this is underneath is the excitation coupling process of the ventricular contraction. If it is not stationary, you can't have the excitation ventricular contraction to take place. चलते हुए हाथ कांपते हुए आप लिख नहीं सकते like that. And T wave is the phase 3 wave when the calcium ions get closed up on the potassium leakage there. So there is slow potassium, slow rising, and the positivity wave is there. And the U wave is the Purkinje wave, delayed Purkinje fibers activation like that, delay position fibers like that. Please. Again, how to rate calculation? If the rhythm is regular, 1 second is 25 millismall square means 60 seconds means 25 into 60, 1500. And if you divide the 1500 by the interval of RR interval having the how much small squares, it will give rise to the accurate calculation of the rate, provided the rate is regular. But if practical purposes, if the less than 3 big squares, it is tachycardia. More than big squares, it is the more than 5 big squares, it is a bradycardia, accurate by this process. I am going away from the traditional method of when rhythm is irregular. Don't calculate the sir, itna se multiply, itna kar rhythm is not. Only point that you can visualize the rhythm irregularity by your vision. Only difficulty comes when the rate is very close one. But inspecting the entire spectrum of the 12 leads, you can say that, sir, there is a slight irregularity I am seeing, so it is something like that, atrial fibrillation like that. Only thing you have to see that if the maximum houses are less than 3 bigger squares, it is tachycardia phase is there. But if it is more than that, that means it is less than the tachycardia. If the bigger squares, smaller squares, bigger squares are more closer, less than 100. It is the ventricular rate which is fasting, which is proceeding at the faster ventricular rate. That is much of significance here. Next. ECG morphology, normal duration, 3 small squares, less than that. amplitude 2.5 less than 2.5 millimeter in the limb leads, less than 1.5 millimeter in precordial leads, Q wave, pathological Q wave, 0.04 second wide, more than 25% of the width of the QRS complex, and these phenomena is more obvious about V2, V3. That's why in the definition of myocardial infarction, it is kept that the lead V2, 3 must be having more than 2 millimeter elevation in the case of the male and the 1.5 millimeter more than the females, otherwise 1 millimeter elevation is sufficient. That is the reason there. PR interval 0.1 to 0.20 seconds, QRS 70 to 100 milliseconds, sometimes 110 millimeters. Free wave amplitude is less than 5 millimeter in eliminates and less than 10 millimeters in pre. All you have to, what I call the morphometry. Always before going to the discussion, before doing the discussion in details, I always measure the morphometry. That's important one. So QR interval is again important for the ventricular dispersal like phenomena. Next please. This chart wise, you all know. Only to say the history important. ST segment depression may be in so many conditions, including the myocardial ischemia, unstable angina, even the some endocardial deposits like that. Hard to say. So conclusion wise, you have to do the history in brief at least. Please next one. This is the home take message. This particular diagram is very much important in life. If you don't understand this diagram, I think you will be drawing the conclusion by only ratu vidya like that. ऐसा है तो ऐसा हो जाए, ऐसा हो तो ऐसा हो जाए. Only by concept this diagram, you could be able to come to the conclusion by merit. The same hexagonal rule of 90 degrees, same this Ithomans triangle I have explained on. Next please. These beautiful diagrams. All the values are placed there. One is that rule is that if the current is flowing, if we keep the electrode away from the 15 centimeter away from the heart, whether you place here, whether you place here, whether you place here, there is no difference in the intensity of the heart. So imputed arm, you can keep here even, you can keep here even, you can keep here, even you can keep here. There is the significance. Bilson terminal combining all the three lamps to be 0, I have always written. The neutral leg. The lead connected to the right leg works as a neutral lead just to complete the circuit, electrical circuit. Otherwise, no electrical circuit will be completed and your ECG not be completely to the mark. Next, please. With these words, I salute the land of Mahatma Gandhi and Lord Krishna, and I have come from the land of the Gautam Buddha and the Lord Vishnu. Thanks to all of you.